Hello, good morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honored guest from India, Professor Ashish Tandon. Professor Tandon is the Chief of Neurosurgery at the Aditya Super Specialty Hospital, Jabalpur, India. He was the previous skull-base and neuro-oncology fellow at the Toronto, Western Canada, and he did his MIS neurosurgery under Professor Charlie Teo. He did his spine fellowship at the Technical University of Munich, and he is also the author of around 20 peer-reviewed articles and 2 book chapters. We're extremely honored to have him today at our webinars, and today we'll be talking about pain blocks for neurosurgeons. The speaker for the second session of today is our honored guest from China, Professor Yang Xiaorong. Dr. Yang is an associate professor of the Fujian Medical University, attending physician of the neurosurgery department of the first affiliated hospital of Fujian Medical University. His clinical specialties include surgeries of the skull-base tumors, gliomas, and other intracranial tumors involving important functional areas of the CNS. We are extremely honored to have him today at our webinars, and today we will be talking about combined endoscopic and transcranial surgery versus purely endoscopic surgery for pituitary tumors. The chair for the first session of today, our honorable faculty from Japan, Professor Norihiro Sakai. Professor Sakai is the chief anesthesiologist and staff physician of the intensive care unit at the Daisuke General Hospital, Aichi, Japan. He is a board certified member of the Japan Society of Neurointensive Care member and of the Japan Society of Regional Anesthesia. He holds a diploma for the European Society of Regional Anesthesia as well. And we are extremely honored and grateful to him for accepting an invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is our honorable guest from Japan, Professor Kenichi Oyama. Professor Oyama is the director and professor of the Department of Neurosurgery at the International University of Health and Welfare, Mita Hospital, Tokyo. His interests include neurotrauma, anterior skull-base, pituitary surgery, and spine surgery. He is also interested in methodology for clinical research and global neurosurgery. He was a previous clinical fellow at the Pittsburgh and Paris, has won several awards and honors during his vast illustrious career. He is a noted author who has also published several articles in various period journals. We are extremely grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President of Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Liu Bun Singh from Malaysia is my co-host for today, and with that introduction I would like to hand over this podium to our first chair, Professor Norihiro Sakai.
Hi, all listeners. I am Norihiro Sakai from Narago, Japan. I am an anesthesiologist and working in regional anesthesia. I will introduce a short topic of regional anesthesia for neurosurgery. First, regional anesthesia gives advantage over general anesthesia by preserving cerebral auto-regulations and facilitating intraperipheral neurological assessment. We expect the reduction of intraperipheral blood loss, improved postoperative pain management, and minimize the risk of hypodynamic instability associated with invasive procedures, and optimizing patient safety and surgical precisions. Second, regional anesthesia with spine surgery has unique challenges, including the need for intraperipheral neuromonitoring and pain management. Regional anesthesia, particularly neuroaxial block, provides precise analgesia while preserving motor function, facilitating arm mobilization, and reducing postoperative opioid consumptions, and reduces the risk of postoperative complications such as urinary retentions and respiratory depressions. Third, cartilage and arterectomy needs good hemodynamic control to prevent cerebral ischemia and ensure optimal surgical conditions. Regional anesthesia, including cervical plexus block, provide effective analgesia and sympathetic block. We expect the stress response and peripheral complications to be reduced. In addition, we wish a favorable outcome with regional anesthesia, including shorter hospital stay and lower rate of myocardial infarction and stroke. Finally, regional anesthesia is essential for awake surgery. We can provide an intraperipheral neurological assessment and real-time feedback while ensuring the patient comfort and comfort during surgery. This technique allows dedicated mapping and avoid neurological deficit. Awake surgery with regional anesthesia promotes early neurological recovery and reduces the risk of postoperative complications and enhancing patient outcomes. Professor Ashish Tandon has completed a fellowship in skull-base neurosurgery at Toronto Western Hospital in Canada. And Toronto Western Hospital is a very prominent facility in the field of neurosurgery and the field of anesthesia. It is very active in performing various styles of the surgery using renal anesthesia. In addition, in Australia, where Professor Stanton received a fellowship of minimum invasive surgery, regional anesthesia is widely used and is a very big presence in regional anesthesia. So we expect Professor Ashish Stanton to give us a wonderful lecture on today's clinical work. Dr. Stanton, could you start your presentation?
Yeah, sure. Thank you. So first of all, my sincere thanks to ACNS once again for this invitation, and I hope that I am able to instill more interest in blocks for neurosurgeons. So my talk today would be focused more on how pain blocks we can use as neurosurgeons. Also, I would be discussing a bit on why we should learn and how you can learn, what are the steps, what are the procedures, and which type of procedures can be done. So this is a very famous scene from a very famous movie in Hindi, wherein one of the professors is explaining how millions of dollars have been spent for astronauts who are in space on how to write. So the protagonist says that why spend so much money on developing a pen when you can use a pencil? Similarly, if you look at this picture here, when you can have great body and muscles with lightweight exercises, why do you want to lift heavy? So what I'm trying to extrapolate here is why you should learn blocks. Now, one should learn, and especially neurosurgeons should learn blocks because it helps clinch the diagnosis. And not just a few times, but many a times it's going to help you. Secondly, definitely we know that it is part of the treatment algorithm. So all of us should learn and use spine blocks. Now, what are the blocks that I use in my practice? So I use erector spiny blocks, which is in almost all of my spine surgeries, I would be giving an erector spiny block. Then I very frequently use transforaminal blocks. It can be a selective root block or transforaminal epidural steroid block that I use. The next that hanging or what's happening? Okay, the next that I use is facet blocks, which can be intra-articular blocks, or I use medial branch blocks as well, and thereafter RF lesioning of the median branch. I use regularly cervical and lumbar epidural blocks, infrequently dorsal, or rather I'll say rare. Caudal epidural blocks, I give sacroiliac joint blocks because a lot of patients come with sacroiliitis to our clinic. And ganglion impar block, I think this is an extremely important block for us because, again, a lot of patients come with coccydynia to us. Now, why blocks? That's quite important. Now, the reason why we should use blocks is because there is a weak association between imaging and cause of pain, especially in chronic cases. So chronic back pain or neck pain, the imaging may not be extremely helpful. And only in 15% of cases, the source of chronic pain can be picked through imaging alone. So, this comes as a big jolt when you read such literature. And that is why we should be able to use blocks. Now, blocks can be diagnostic blocks or they could be therapeutic blocks. Now, you have to understand the difference. When you are using a diagnostic block, you are trying to pinpoint and use it for your diagnosis. It's like an MRI or an X-ray, or clinical examination. It's something like that. So a diagnostic nerve root block is used to clinch the diagnosis and to find out the source of pain. Secondly, it pinpoints pain generating root level and the facet joint. Now, generally for diagnostic nerve root blocks, lidocaine is used of approximately 2%, 1 ml used along with dye. And the patient should have at least 70% relief in his pain to consider the diagnostic nerve root block as a positive result. The diagnostic value, however, is moderate, and you have to combine your history, examination, MRI, X-ray findings, as well as this block to finally clinch the source of pain and to find the and to diagnose the cause of his pain. The frequency at which we can use blocks is approximately 3 to 4, and it is considered 3 to 4 is considered as safe per year. And one must remember that there should be at least a gap of more than 2 weeks between the blocks. The contraindications, well, anticoagulants, if the patient is on anticoagulants, don't give blocks or try blocks. Local site infection is a no-no. Systemic infection, try to delay the procedure till everything is under control. In pregnancy, use ultrasound. And if the patient has allergy to contrast or local anesthetic agents. Now, what are the type of steroids that we can use? So right now, what I am focusing in my lecture right now at this time is what are the drugs that you can use. So you can use local anesthetics, as I have just elaborated. And now the type of steroids. So you have two types of steroids. One is particulate, but the problem with particulate steroids is it can cause anterior spinal artery thrombosis. There could be spinal cord related issues. And the particulate steroids include triamcinolone, methylprednisolone, betamethasone, etc. The next group is non-particulate, which is mainly dexamethasone. Now, when I say non-particulate, it means the particle size is 10 times smaller than RBC. And generally, dexamethasone will not, or non-particulate would not aggregate. So it's not that, 10 molecules or 10 particles of dexamethasone are going to make a big particle. Now, the importance of this is when there is particle aggregation, they can increase then the size of the RBC and they can start blocking vessels. And we have reported literature on anterior spinal artery thrombosis or other vascular complications with particulate steroids. Now, the advantage of non-particulate is not just that the complication rate is lower. However, there is no difference in functional or analgesic outcome between particulate steroid and non-particulate steroid. So if there is no difference in the result, then why do you want to use a drug which has more complication or side effects? And that is why I strongly recommend non-particulate dexamethasone as the drug of choice or the steroid of choice to be used. Now, the question next comes up is why use steroids? What is the rationale? The rationale is steroid, when you are giving locally, it inhibits phospholipase A2, causes a decrease in inflammation. It inhibits neural transmission in nociceptive fibers. So the pain drastically comes down. Now, look at this, article by Ryu et al. It is comparison of epidural steroid injection versus just giving bupivacaine injection in a patient with disc prolapse. Now, when steroids were given, only 23% of patients required surgery. However, when steroid was not used and only a local anesthetic was used, for example, bupivacaine, 67% patients required surgery. That means there is almost a 50% reduction when you are using steroid as one of the agents in your block. Now, let's talk about the type of local anesthetic and the dye. Now, viscosity of different local anesthetics is similar. And why is viscosity important? Because when there is higher viscosity of whether it is a dye or a local anesthetics, the spread is less. Now, dye is much more viscous, so it will spread to a limited area. However, local anesthetic will spread more than the dye. So what it effectively means is that suppose if the dye is at one level, you can be rest assured that your local anesthetic and steroid would spread much more than the dye. The volume of drug would also decide the spread. So you have to use lower volumes for a selective nerve root block or a diagnostic block. Whereas when you have to give a therapeutic block, or when you're giving a planar block, when you want to have multiple levels of block, like intraoperative blocks or sorry, blocks after major spinal surgery, then you can have larger volumes which will spread across many levels. So higher volume, it will spread to adjoining structures and decrease the specificity. So, when you give a lot of anesthetic and steroid, then there'll be multiple pain generating structures which will get blocked. So the patient is pain free, but you really don't know what is the diagnosis and which structure you have blocked to give the pain relief. So when you are giving a diagnostic block, please use smaller amount of drug. When you are giving a therapeutic block, you can increase the volume. Though there are also different other criteria to decide the amount of block. As far as pregnancy is concerned, it is a relative contraindication for these blocks, mainly because of fluoroscopy. So you can, if you are trained, you can use ultrasonic guided blocks. Now, the next question that may crop up in the listener's mind is whether to use fluoroscopy or intraop C-arm, or do we use a CT scan? So the advantage of fluoroscopy is it's faster and it is easy and widely available. It has a better non-axial view. So SAG or AP coronal views are better in the sense you get it fast, quick. Also, you have a real-time view of the flow of the dye. So you can keep it on, and you can, when you're injecting the dye, you can have the fluoro on and you can see how it flows. However, the disadvantage is there's radiation to the surgeon and you cannot get axial views. So you will only have non-axial views. Now for CT, there's excellent axial and 3D views. You can precisely point the needle. Operator radiation is not that high. Though the disadvantages is it is more time taking, there is increased radiation to patient, and real-time views are absent. So in my practice, almost 99% of the times I would go in for fluoroscopy. So now, after I have given you a general overview, I would go on to specific blocks. So first, I would be speaking on erector spiny blocks. Then I would be speaking a bit on transforaminal blocks, epidural blocks, facet blocks. And I think even if I am able to do all this in the time limit that I have, it would be sufficient. So what is erector spiny block? And I am pretty sure that after you've heard this lecture, each and every spine surgeon can go back to his theater and he can start using these blocks from tomorrow itself. There's hardly any learning curve. Now, what is a erector spiny block? It was started by Ferrero et al. In 2016. It's a facial plane block. So you are injecting the drug in a particular plane, and the drug will spread in a particular plane. So here you are depositing the drug, as you can see in this photograph, below the erector spiny. So peri-op pain reduction is dramatic. In fact, after thoracic surgery, it was introduced for that, but now it has been extended for use for cervical surgery or for thoracic, abdominal, lumbar surgery. And in my practice, again, I use erector spiny blocks before my endoscopic discectomies, endoscopic lumbar canal decompressions. I use it for adolescent idiopathic scoli, trauma, etc., etc. So almost there is hardly any spine surgery where I would not use an erector spiny block. So it has also been included for the multimodal analgesia, which is the ERAS program. And it's very easy. You have to target your needle in between the tip to the lateral 1/3 of the transverse process. It can be fluoroscopic guided, it can be ultrasound guided, and the needle rests between the tip of the transverse process and erector spiny muscles. And there are a lot of nerves going through there. What I do is inject 20 ml of 0.25% bupivacaine or 0.2% ropivacaine, and it is deposited on either side. I use bilateral, except when I'm doing a unilateral discectomy or over the top lumbar canal decompression. The drug spreads craniocaudal. So if you look at this diagram, if this is the transverse process, your needle is coming here. It can be under ultrasound, or you can do it under fluoroscopy, and the dye spreads. And the local anesthesia or local anesthetic agents would spread. It acts both on ventral and dorsal rami. So mainly when it is acting on the dorsal rami, it's giving pain relief. So this is to show the spread of the drug in animation and in real-time fluoroscopy. Now, how effective is the erector spiny block? Well, I would still say that the jury is out, and we do not have a clear sort of level 1 evidence. However, erector spiny block provides, as in this study, which was in BMC anesthesiology just in 2023, that erector spiny block provides less opioid consumption, lower pain scores, and longer time to first analgesic request by the patient. So if it is such a simple block to use, why not try it? And when you can avoid or at least decrease the use of opioids. Now, there can be complications. There could be partial lower limb weakness if you're giving it in lumbar erector spiny, because it is also acting in the ventral rami. However, I am yet to come across a patient where I have had lower limb weakness. It can also cause local toxicity of the anesthetic drug because you're using a little higher amount, but you have to calculate according to the patient's weight. So that was about erector spiny block. Now the next focus is epidural blocks and transforaminal blocks. Dr. Raja, can you just inform me 10 minutes prior?
Sure.
My time is so that, I at least focus on the most important things.
Okay.
So epidural blocks. Now, what is epidural block? You are depositing the drug in the epidural space. Okay. Wherever you think that the pathology is. So you can target epidural space through the transforaminal approach, through the newly described or relatively newly described paramedian interlaminar approach, or the standard midline interlaminar approach for the epidural steroid or epidural block. Now look at this major sport trial. It was a benchmark trial, the spine patient outcome research trial. Now what does it state? It states patient of disc herniation receiving epidural steroid injection. In such patients, 20% would require surgery versus almost 60% requiring surgery in the non-epidural steroid group. So when you are using epidural steroid through any which route, I think you are decreasing the chance that he may require surgery. Having said that, the indications of surgery remain the same. There are specific indications for using epidural steroid. Now, as I told you, epidural steroid you can inject mainly through transforaminal approach or the interlaminar approach. Now you can see the two photographs. On the right side, this here is the transforaminal, and here is the standard interlaminar epidural steroid. Transforaminal approaches have better results. They have lower complications. And the reason is you are depositing the drug very near to the site of the pathology. So the drug is being deposited mainly in the ventral area or anterior area where the pathology lies. Say disc herniation has happened and there is radiculopathy. Coming to transforaminal blocks, I'll speak on epidural steroid a little while later, but just wanted to highlight transforaminal blocks because it is the workhorse. So you can do a selective nerve root block, which could be supraneural. And what I mean by that, I'll just explain. And then you can have a transforaminal epidural steroid block, and which will block the traversing as well as the exiting route. So you can give a selective nerve root block, one, through the transforaminal approach, or you can give a epidural steroid block, blocking the traversing as well as the route above. So you can use transforaminal route in both fashions. Now, coming to basically transforaminal blocks, I've already introduced you to this. This was a separate lecture, but I have included in here. Now, look in the picture here. This is a transforaminal steroid block where you have given transforaminal steroid to the epidural space, as well as you are blocking the nerve which is coming out. So you are using it as an epidural steroid block as well as a root block. Now, what are the indications? The most important indication is radicular pain, secondary to disc prolapse. This is the most important indication. Then you can also use it for lateral foraminal stenosis. You can use it for post-laminectomy syndrome with radiculitis, failed back syndrome, post-traumatic or post-herpetic radicular pain. So wherever you need to block the nerve, this approach is excellent. Now, quickly on the way to do a transforaminal block. So look here, this is the radiology of the foramen. Obviously, we are coming lateral to medial to enter the foramen. So the patient is lying prone, and the foramen is oval in shape. It has about 2 centimeters of height, and there is progressive widening as you go caudally from in the lumbar space. Now, the exiting route is in the superior part of the foramen here. So when I said supraneural block, I meant that you inject the drug here. When I say infraneural block, what I mean to say is you inject the drug here. Okay. Now, this drug, infraneural, you can go inside, like more into almost where the theca is. So if suppose, how do I show you? Yeah. Suppose this is your theca and this is your exiting route. So you can push your needle right up till this point and inject. So it will block not only this nerve, but this nerve as well. So we all know about the Camden safe zone, and it is here that we inject the drug. So the end plate, the base is formed by the end plate of the lower vertebra. The perpendicular area is formed by the SAP or the traversing route, and hypotenuse is the exiting route. So exiting route, the superior end plate of the body, and the superior articular process. So this is the Camden safe zone. You can put in steroids right here. It's going to block this as well as the traversing route. So exiting route and traversing route both get blocked. So again, to show here, there are 2 safe triangles. One is the supraneural, which is this, and the other is infraneural, or where the Camden's triangle is. Now, the foramen becomes more wider as you go down, and it is widest at L4-5. L5-S1 again becomes narrow, and it may be a little more tricky to do a L5-S1 root block. Now, the technique, I use two techniques. I'll quickly demonstrate both. One is the parasagittal approach. This I mainly use in L5 S1 in view if bony restriction for lateral approach is there. What I mean to say here is that I use just a parasagittal or the traditional transforaminal block for L5S1. What I mean by that is, if I'm very close or just lateral to the facet, I would mark my entry and I'll push the needle inside the foramen. The far lateral approach is my personal preference because I tend to do transforaminal discectomies as well, and that is where I use it. So there are three different locations for the needle in transforaminal block. The first is supraneural or subpedicular. The second is retroneural, and third is retrodiscal or below the nerve root. So you can give at any of the 3 points. So basically it's supraneural and infraneural blocks. Now let's focus on parasagittal approach. That's for L5S1 mainly that I use, though it can be used for any level. The patient is prone, parts are prepared, confirm the level using C-arm, and oblique view or a Scotty dog view is used. So you use a oblique view. This is the prone patient head, foot end in here. And if you look, this is the Scotty dog that you get on an oblique view. Now, this is where below the pedicle you have to target. So you can go bang on and enter the transforaminal area. So transforaminal window is identified. Then I use a 22 gauge needle with a gentle bend at the tip is passed under fluoroscopic guidance. So subpedicular or supraneural approach, that is what you can use for a nerve root block of L5. So exiting nerve root block of L5. So look here, this is the Scotty dog view that you are getting. The transverse process, the pedicle, this is the foramen. This is just supraneural because the nerve root is going to come and go like this. And these are the three views. You should have an AP view with no parallax, specifically at the level where you are going to inject the drug. Then you have the oblique or the Scotty dog view, like it has been shown here, and this is where you have to place your needle. Camben's triangle I have already spoken about. Now, why I avoid supraneural approach and why I prefer the Camben's triangle is, another reason is supraneurally you may have vessels. So you may have vessels arising from the segmental artery and you can have a hematoma there. Whereas in the infraneural part of the foramen, there is hardly any structure that you can injure unless you really go too medial and hit the dura. So in almost all cases, I would prefer an infraneural approach. So in here is a typical L5S1 block. So this is again a supraneural, and there is one more view that you can get, which is the contralateral oblique view. Anyway, so the technique is confirm position on AP and lateral views after you have introduced the needle in the Scotty dog view or the oblique view. Once you have confirmed the position, you inject the dye and then you inject the drug. So this is the Scotty dog on the opposite, like the other side, and you confirm the position of the needle on AP view, and thereafter you inject the drug. Like in here, if you see the needle has gone infraneural, this exiting L5 root is getting blocked, and there are specks of epidural steroids as well. So if you inject some more dye or drug, it's going to block the S1 as well. So epidural steroid, and you can block two routes. This is just to show you a specific route block of L5, and here you are blocking S1, but this is through a transforaminal S1 foramen. Now, as I told you, I prefer the lateral approach. It's the same approach as for transforaminal discectomy, where the needle is coming from far lateral. I personally, in my practice, feel it's quite easy, and you can hit the lower part of the foramen, as well as you can go really medially, where there is the lateral edge of the theca. So, I prefer this sort of approach. Also, for those who want to learn transforaminal discectomy, you have to know how to guide this needle into the disc through the transforaminal approach. Now, the disadvantages of lateral approach for L5-S1, the problem is there are three bony structures which are obstructing the needle placement. You have the sacral ala, and you have the transverse process, and you have the iliac crest. So there are a lot of structures which would block you, and that is why you just go parasagittal, and you take the needle from parasagittal area into the foramen rather than coming far lateral. So for L5-S1, especially high iliac crest, it's a very difficult proposition. Now, quickly, again, AP view, no parallax in a patient who's prone. On AP, you might mark the skin. Then for lateral X-ray, for L5 and L4 level, my lateral marking would be at the apex of the facet joint here. And that would be my entry. So whereas at the higher level, it will be the tip of the spinous process. And that's because the peritoneum would be, it will be much closer in here. And I don't want to injure anything intraperitoneal. So when I meant lateral, in the lateral view, when you are marking for the needle entry point, you can go much lower, much anterior for L4-5 and L5-S1, vis-a-vis L3-4 and above. So here I have done the markings. Once the marking is done, then I get the needle inserted. I confirm with regular AP and lateral. And for L4-5 and L5-S1, you just have to go above the iliac crest. Once trajectory is certain on the AP view, you shift to lateral and then you insert the needle. So cranial, caudal, this is the needle coming infraneural. Like this is an operated, I'll skip this. I'll just skip this part. This is again to show confirmation of AP on dye for transforaminal insertion of the needle. Again, once you have confirmed that the needle is in the foramen, you inject the dye, you can do a discogram, you can do a transforaminal block, you can give a specific route block, you can give a epidural steroid block. Drugs I have already discussed, so I'll quickly skip this. Again, I have elaborated before. Onto the complications that can happen with transforaminal steroid. You can have bleeding, epidural hematoma, infection, allergy, nerve injury, transient numbness. You can injure the dura, and you can have side effects of the drugs that are being used. As far as transforaminal epidural steroid injection is concerned, this is a systematic review and meta-analysis of efficacy and safety. Now, what are the results? Radicular pain secondary to disc herniation. There is level 1 evidence of benefit at 3 and 6 months. So if acute disc prolapse, severe radicular pain, don't jump in for without any neurological deficit. Do not jump in for surgery. go in for a transforaminal epidural block. So it's a big base of a group of patients who are in between the conservative and surgery. And this is where transforaminal blocks come in. Now, pain secondary to central canal stenosis, you just have level 4 evidence. So not very strong evidence for that. Failed back syndrome, again, level 4 evidence, so not very good. Pain secondary to lateral recess, again, very poor evidence. So basically, it is more for radicular acute symptoms secondary to disc or foraminal stenosis or even extraforaminal disc herniations that you can use this. So the take-home message is transforaminal epidural steroid is very important technique in one's kitty. Best for radicular pain, as I have already elaborated. Learning curve is not steep. You need to learn. You can learn it in, say, 3, 4, 5 procedures under someone who is experienced. There is a range of complications, but the risk is very low and due diligence and safety is required. So at this point of time, I'll just take a quick break in the sense to summarize on what we have already discussed in this webinar. So I started with why we should learn blocks, what are the indications, what are the types of procedures I do, what are the drugs, local anesthetics, what are the steroids, which steroid I use. Then I talked about erector spinae plane block. Then I compared transforaminal and epidural interlaminar. Then we had a long discussion on transforaminal blocks, both parasagittal transforaminal and far lateral approach. And for me, except other than L5S1, far lateral is the way I do. Now, the next half of the lecture, I would be talking on epidural blocks. So that epidural blocks would be interlaminar epidural blocks, paramedian interlaminar, caudal epidurals. It could be caudal, lumbar, and cervical epidural blocks. So that is one. And if I have time, then I'll also discuss about facet blocks and median branch blocks. Now, what are the indications for epidural blocks? Well, as I have already mentioned, disc herniation or degeneration. You can have radiculopathy, be it cervical, thoracic, or lumbar, spinal stenosis, facetal arthropathy, sympathetic mediated pain, or in certain cases of pelvic pain, though I have hardly any experience in that. Well, this is a chart just to mention about epidural and anticoagulant and what is the consensus statement of ASRA for how many days you have to stop the anticoagulant before you can do the procedure. So important is if the patient is on NSAIDs, you don't have to wait, you go ahead. And then you have for clopidogrel 7 days, ecosprin 5 days, etc., etc. Now, let's see the results of epidural injections for lumbar radiculopathy. In a meta-analysis, level 1 evidence for steroid plus local anesthetic for lumbar radiculopathy, and level 2 if you're just using local anesthetic. As far as axial discogenic pain is concerned, level 2 evidence. So there is moderate to strong recommendation for long-term improvement. So for radicular pain, you have level 1 evidence. For axial discogenic pain, you have level 2 evidence. So they are pretty good. Now, again, these are some more studies. However, for spinal stenosis, if you're giving a caudal epidural, only level 3 evidence, interlaminar level 2 evidence, transforaminal, as I have already spoken before, level 3 to level 4 evidence. So the best is giving an interlaminar injection at the level of stenosis has one of the better results. Now, this is very interesting. I would strongly again push all of my viewers here to use cervical epidural block, learn it. It gives excellent results for cervical disc herniation with radiculopathy. especially acute with far lateral discs. So indications, cervical PIVD with radicular pain and chronic neck pain. These are the two indications. Now, as far as cervical epidural site is concerned, either you give it at C6, C7 interlaminar space or C7, D1 interlaminar space. Above C6, there's very limited epidural space. Though with experience, you can also negotiate into C5, C6 epidural space. So here is the technique. You need a 22 gauge 2He needle, and the patient is in prone, head flexed. You need C-arm, dexamethasone, non-ionic contrast, and I use bupivacaine. So I'll quickly elaborate the procedure. There is a small support under the chest, and the patient is flexed at the neck to open the space, C6, C7 or C7, D1. You prepare the parts. It's very important to have the upper limbs by the side of the patient to get a good fluoroscopic image. You turn your fluoroscope in an angle so that you have a proper trajectory to the interlaminar epidural steroid. So as you can see, this is your starting point here. Interlaminar, you remove any parallax. Then you gradually, after giving local anesthetic, you gradually push in the needle on AP, and muscle will give you soft feeling and the ligament will have a firm or gritty feeling, and you progress gradually, and then suddenly you will have a give way. At that point of time, you can turn your C-arm to lateral in case if you are able to visualize C6, C7, or in AP C7, D1, you inject the dye. So once the needle is in position, once the needle is in position, you confirm, you attach the empty syringe with air, and you gently push for the air to get in. If it is in the muscle or if it is in the ligamentum flavum, the air will not go. Once it is into the epidural space, the air will suddenly gush out of the syringe, or when you push, it is very easy. There's no resistance as such. So here is on lateral. You have the laminospinal line. You do not cross beyond. So you cross the spinolaminal line, but not too much inside. Here you give the drug will flow up and below. So even C4, 5 radiculopathy, C5, 6, C6, 7, all can be dealt through this approach. So here the needle is pointing more towards one side, and the dye is also going, it's more onto the side of the needle, as you can appreciate in this photograph. So I use 1.5 ml of 0.25% preservative-free bupivacaine, or the heavy bupivacaine, along with 2 to 4 milligrams of dexamethasone. After drug delivery, please see that the dye is flushed. You should know till where it has spread. Observe the patient closely for any respiratory problems. In your initial few cases, or in fact, in most all cases, you should have a backup anesthetist with you in case if there is any problem. So this was about cervical epidural. Coming to lumbar epidural, which is again the bulk of our cases. The indications include acute radicular pain, chronic back pain secondary to lumbar canal stenosis, or a chronic disc, failed back syndrome with axial pain. Now here, again, there are different techniques. You have the standard midline interlaminar technique, which is this green line. Then you have the paramedian interlaminar block, which is this line. So here again, you are trying to reach the axilla, as we say, the epidural space in the axillary area. And the other two, I have already talked about transforaminal epidural block, and I might speak on caudal epidural block as well. So here, the technique the patient is positioned prone with a pillow under, but please note that this photograph does not demonstrate the exact position. The patient should be much more in front so that you have an AP view, and you can have a tangential oblique view also, something like this, so that you can remove parallax if there is any. So once there is opening of the interlaminar space through this position, you again infiltrate local, and you can push in the needle. This is just to demonstrate the entry for the paramedian interlaminar approach. So as far as C-arm position is concerned on AP, there should be proper squaring of the vertebra, especially at the level wherein you have to give the epidural block. So as you can see, there is no parallax here. Ideally, there should be no parallax of the lower vertebra as well. Now, these days, again, there's a contralateral oblique view that is being used that also gives an excellent view of till what point do you need to enter. Once you have entered the epidural space, again, you have to push the air through the plunger. And once there is no resistance, you use dye. You see the flow of the dye. And once you've confirmed, then you deposit your drug. Again, use bupivacaine and dexamethasone. The patient, after injection, is kept prone for 5 to 10 minutes and then made supine. Facet joint pain is the next. Now, please look at this slide. 67% of neck pain is secondary to facet joint. 48% thoracic pain, 45% low back pain as far as chronic pain is concerned. So this number is huge, and we are missing these patients. So you should know what is the presentation of facet-mediated pain in lumbar. The photograph on the right side shows. Similarly, you should know the cervical facetal pain presentation. You can give facet block in two ways. One is intra-articular facet block, where it is more of a diagnostic block where your facet, you are sort of injecting within the articular space. I'll not go into the causes of the facet joint pain. The volume that you can inject intra-articular is not very high. It's less than 1.5 ml. And you should use short-acting local anesthetic lignocaine so that in case if there is accidental subarachnoid injection, it will not affect the cervicomedullary area for long. So in cervical facet joint, inject 1 ml, and the lumbar area, there's higher space, so you can give more. For lumbar facet block, you get an oblique view, the typical Scotty dog that I talked about. You have the lumbar facet joint, get in, inject 0.2 ml of contrast, and then steroid. There are a lot of literature propagating for the facet block. Now, the next is medial branch block, which is the branch of the nerve supplying the facet. So one facet joint is supplied by two medial branches. And so you have to block two medial branches to sort of get a medial branch block. I'll not talk about the technique here because it's a long part, and I would leave this. If the median branch block diagnostic confirmation is there, go for a RF of facet joint, and it's going to give a good relief for 6 months to a year. The other block that I use is SI joint block, then coccydynia, wherein I use a ganglion impart block. That is another very important block one must learn. It's very easy. There's a needle-in-needle technique. You just go between the sacrococcygeal area and hit the ganglion impar. You push in the dye. There is a comma shape that you get. Once you get that, you push in the drug. If the patient has relief and recurrence, you do a RF of the ganglion. To finally inform that one must also have this important weapon in your armamentarium, which is radio frequency ablation for trigeminal neuralgia. Perhaps I'll get another opportunity to speak on this. So the take-home message is learning spine blocks should be part of neurosurgical curriculum. You cannot have a neurosurgeon untrained for these spine blocks. It's very important. It will enhance your management algorithm. There is a wide variety of blocks for various presentations, spine, limb pains, then headaches, trigeminal pains, facial pains. So there's a huge array of pain blocks that you can learn. Use fluoroscopy, learn how to move the fluoroscope and how to have a head-on view to push in your needle. You can also use CT or ultrasound guided. The learning curve is not steep. For a neurosurgeon who's clipping complicated ACOM, basilar top aneurysms, and other petroclival tumors, you can very well understand that the learning curve is not steep. So please learn, please include this in your armamentarium. Many thanks for this time. Thank you.
Thank you for the very excellent lectures. And it is a very useful information to summarize the pain blocks. I think not only pain clinicians based on the anesthesiologist, but spine surgery also the provider these pain blocks. It is very important. So I have one question. Now the spine paravertebral or the spine block is now usually used not only the fluoroscopic imaging, but ultrasound imaging. For example, epidural under facet block or other some spine blocks. Some anesthesiologists is using ultrasound imaging very frequently. So, do you use ultrasound imaging frequently?
Oh, yes. The ultrasound is coming in a big fashion, not just for the blocks, but also for neurosurgery as such. However, the sad story in our country, not a lot of neurosurgeons are into blocks. So because neurosurgeons are not doing blocks, they are not trained even for using fluoroscopy for blocks. So the first step is to learn it through fluoroscopy, understand the anatomy, and then jump on to ultrasound to reduce radiation. And, ultrasound blocks you can do even in wards in certain cases. Like I'll just give you an example. I do ultrasonic serratus anterior block for rib injuries. And I've got excellent results with the serratus anterior planar blocks. So ultrasound is the way to go, I think.
Thank you for the comment. And I will make one opinion to all the listeners that from the anesthesiologists that a spine block is very, very important, but dangerous because when you use spinal block in the anticoagulant or the anti-platelet therapy, some dangerous situations are coming. So could you please check the medications or the anticoagulant and anti-platelet? And local anesthesia toxicity is very, very severe and crucial situation. So could you please keep in mind? Thank you so much.
Thank you.
Thank you very much. We have one raised hand from Joe. Hello, Joe.
Hi, Raja. Thank you. Thank you so much, Prof. Ashish. That was a very enlightening lecture. Thank you so much for your sharing. I have two questions. I noticed that you prefer DEXA most of the time, dexamethasone. Why is that in comparison to triamcinolone, I mean the particulate and the non-particulate steroids? Even in the number.
So, previously the theory of using particulate steroid was that the steroid would last at the site where you're depositing it for a longer time. And that it was supposed that it will be more effective than non-particulate. But now we have good number of studies suggesting that there is no difference between particulate and non-particulate as far as not just the percentage of patients who are getting benefited, but also the duration of the effect of particulate versus non-particulate. So initially, say about almost 7 years or 8 years back, I shifted from particulate to non-particulate. From particulate to non-particulate. Though I never had any serious complications with particulate, but looking to the literature, it forced me to shift to non-particulate or dexamethasone.
All right, thank you. My second question would be, you said you give transforaminal blocks for this prolapse. How early do you decide to give these blocks if they don't have any neurological deficit and their main symptom is pain?
Okay, so it totally depends on when the patient is coming to me. By that, what I mean is am I the first physician he's coming to, and am I the first to start medication? If I am the first, then on the first go, I do not suggest blocks. And I would just go in for NSAIDs and other conservative measures. However, if I see that the pain is severe, not getting benefited with medication, or if the patient has already had medication from previous physicians, which have been appropriate, then I would advise even on the first visit.
Right. So one round of medications first.
Yeah.
Okay,
Or
thank you.
if the patient has, if the patient has partial benefit from the drug, then again, I'll extend it for another 10-15 days and then try more of conservative, then go in for block. However, if it is less than 50%, I would suggest a block right away.
All right, great. Thanks.
Thank you very much.
Thank you.
Yes, Dr. Opara.
Okay, thank you so much, Prof, for your presentation. It was very nice and lucid. I just have a question. You mentioned in your presentation about waiting for a period of 2 weeks in between blocks, and I wasn't quite sure of what that was about. Is it that you have to, there are some situations where you need to give these blocks frequently, or why do we have to wait 2 weeks between blocks?
Yeah. So see, obviously you are going to use a repeat block if there is a poor response. Otherwise, why would you go in for another shot of the block? So it is well documented that steroids at times take time to respond. That's one. Number two, this 2 week or 3 week period has come from particulate steroid theory, that when you deposit the particulate steroid, it is there and it is gradually releasing the drug, or it is in contact, and so that is the minimum time you give for your first shot to act before you decide that, look, okay, this is not working, I am going to do it another level or at the same spot once again.
We have Prof. Mathuria's hand raised. Prof. Mathuria.
Yes.
Please.
Dr. Ashish, congratulations. Nice.
Oh my God, sir! It is such a pleasure to be before you, sir. It's an honor, sir.
I'm really proud of Jabalpur. What have been done by Yadram. It's an excellent department, and what you are doing. I'm really proud. Very nice. Though I don't have any personal experience on the blocks myself, but I'll just talk about my philosophy and how should we proceed, because there are so many young people who are there with us to learn about these things. There are few comments and few questions. The comments are that the resolution of the CT scan is far better than that of the fluoroscopy.
No doubt about it.
That is one. So in that, if required, particularly in the cervical region, you may have a CT scan then followed by fluoroscopy for real time. That is one. Then the other thing is, as you told about the learning curve. Learning curve is okay, not much at the place where there is no cord. It is just the roots, that is the lumbar region. But the learning curve is more in the place where you can have more complications related to anterior spinal artery and the cord, that is the cervical region and the dorsal region.
Yes, sir.
These are the comments. Then say whatever is the place where there are more complications expected, which I already narrated, then you must have the excellent resolution. Not to minimize but to obviate the complications.
Yes.
Because even the minimization may lead to problems. This should be a absolutely no complications in the region where we are doing the cord. That
Yes,
is,
sir.
and the other thing is that no time we should be. This is for the audience who are there. No time the compromise on the surgical techniques for the disc surgery. If somebody has got a large disc, which you think that it's going to give rise to complications, should be operated. If there is a neurological deficit, in that condition, you must emphasize that the patient has to be operated upon, no blocks, no drugs, nothing. Because otherwise the message should not go that you give the block and the fellow's pain is relieved. Don't give it, don't give even non-steroidal anti-inflammatory drugs. Because if you give and the pain is relieved, he even continues with the deficit, which should not be there. I think every neurosurgeon will agree with that. But for the youngsters, I want to pass on this message. Then the question is, you told that we should be given the less volume of the drug. Is it possible that is there a concentrated anesthetic drug available so we can give the less volume? This is
basically, sir, generally what happens is first, the viscosity of all the local anesthetics, be it the lignocaine, bupivacaine, ropivacaine, which are the commonest ones, is the same. However, ropivacaine has more effect on the sensory, and it is much more cardiac safe as well. So either bupivacaine or ropivacaine can be used with smaller volumes. Now, that is more true for cervical facet joints, not for lumbar. The reason is, as we all know, that the ligamentum flavum forms a part of the capsule medially towards the cord. And so the breach or the drug flow can happen suddenly into the spinal canal. So that is why you have to use lower volume. Now, the problem is lignocaine has short acting, whereas bupivacaine and ropivacaine is longer acting. So the scientific community is divided. One says that, look, if there is a problem, then the problem will get cured much faster if you use lignocaine. The other says that, look, ropivacaine and bupivacaine, you use smaller volumes because they are more effective and longer duration. So, sir, the community is divided. I continue using bupivacaine, and I just use less than a ml for cervical facet blocks. Sir.
Is it possible we use both?
Sir, I think that's a googly for me because I haven't read the use of these two, and I should go back and I'll read on it. You are a master of
Raja, so you will pass it on to others also.
Yes, you are a master of spin ball. But for your comments, sir, I have one very important message for the audience, and that is, sir, here when I am doing a block, I am doing it alone. When pain physicians are doing, who are mostly anesthetists, they are doing it alone. But if you look at the West, especially if you look at, say, Australian pain physicians who are anesthetists, who are trained anesthetists, who are practicing anesthesia, for them, it is a must to have a standby anesthetist if they are giving a pain block. That is by rule. So, as you said, that, we should not have any complications and we should have safety as our priority. I would not agree more for your comment, which you have provided here.
No, I couldn't follow what the last line, what you mean.
Sir, I said that your comment regarding prevention of complications in any which way is very well taken, sir. It is a very important thought which must be adhered 100%.
Say, one thing is, when we say that the anesthetist should be there, because sorry, please don't mind, it's a neurosurgical community. I don't mean that I am favoring neurosurgeons in front of the neurosurgeons only, but as far as possible, most of the time the neurosurgeons are magnanimous. That's the
Yes, yes.
reason we say that the anesthetist should be there with us, because we want the 100% safety of the patient. If there are the anesthetists who are giving the block, they also should have a neurosurgeon with them, because neurosurgeon is far more precise than them about the neural structures. I think you will agree with me on that.
Yes, sir.
Thank you.
And
Thank you very
anything,
much, Prof.
last question. Say anything you can give the best possible for the failed back syndrome, because everybody has faced this problem.
Basically, sir, sir, as you know, I keep on telling to my fellows, if you know the cause of fever, you will treat the fever. If you know the fever is secondary to malaria, you will treat it, no problem. However, if you don't know whether the fever is because of COVID or malaria or dengue, your treatment is going to fail. That is again, to extrapolate that is the biggest problem with failed back syndrome, that we really are not able to hit the nail on its head. What is causing failed back? And these blocks, sir, must be used for finding the cause of the failed back syndrome. Once you know the cause, that look, it is this particular facet, or if we have caused neural damage, or there is still facetal arthropathy which is causing, or it is instability. Once we know what is causing the failed back, we'll be able to manage it much better than what we are doing it today.
Okay, thank you, Raja. I have taken some time, but it was required.
Thank you very much for this exhaustive discussion. And I understand it's now time. So first of all, let me thank Prof. Ashish Tandon and Prof. Noriro Sakai for this beautiful session, and all the panelists for this wonderful discussion. I want to update to all the audience that we have an update from Prof. Shubin that this is being broadcasted on WeChat, YouTube and Zoom, and we have around 512 people who have joined from all over the world to watch this live. Thank you. So we'll move on to the second session, and I'd like to invite our very honorable guest, Professor Kenichi Oyama from Japan, to say a short introduction about the topic of combined surgeries versus pure endoscopic for pituitary tumors. Prof. Oyama, all yours.
Thank you, Roger. Hello, everybody. I'm Kenichi Oyama from Tokyo. It's my great honor to chair the session. The next speaker is Professor Yang Jiarong from China. The title of his lecture is Comparison of Combined Transnasal and Cranial Surgery with Pure Endoscopic and Nasal Surgery for Pituitary Tumors. So, Professor Jiarong, please start your lecture.
Okay, thank you for your introduction. Thank you for everyone. And this is a great honor for me to share some of our works here. And today our topic is joint and irregular pituitary and cranial tumors surgery, comparison of the simultaneously combined endoscopic and the nasal and transcranial surgery and pure endoscopic endonasal surgery. And this is from our single center experience. And I'm from the first affiliated hospital of Fujian Medical University. And as we all know, that because the lack of the bone structure above and the lateral to the center trigger makes it easy for pituitary tumors to extend or evade the suprasellar and the paracel regions. So anatomically, about maybe 80% of the joint and the irregular pituitary endocranial tumors may extend towards the cerebrotracheal and may exhibit lateral or lobulated growth. And from the figures, we can see that there are ligaments, arteries, nerves, consist of some triangles that for pituitary adenomas, if the tumors grows upward, it may go through this kind of space or gaps. But for neurosurgeons to reach or to resect this kind of tumor from these gaps or spaces so hard, because you may difficult to avoid the injury for this kind of important structures like the arteries and nerves. And as we all know that if the tumor residue often cause some bleeding in this area, and it may cause very serious problems to the patients. And we define that the some point below as the giant and irregular pituitary and endocranial tumors, GIPNet. The first point is the maximum diameter greater than 4 centimeters. And the second point is the prevalence of the GIPNet accounts for approximately 5 to 14% of all pituitary tumors. The third point is significant intracranial tumors attention to one or more of the following regions like anterior skull base, interpendicular citizen, paraceratic area, middle cranial fossa, third ventricle or left ventricle. The fourth point is the tumor breaches the sedal diaphragm or affect nearby neurovascular structures such as the cervical valley, optic chiasm, hypothalamus, and main cranial nervuses. And the 5th point is this is a heart tumor structure. And the last point is recurrent tumors accompanied with the numerous fibrous scars. The GIPNet is a typical growth or accompanied by breakthrough of the diaphragm set that goes beyond the fields of the endoscopic view. Even if it is visible under an angle endoscope, surgical instrument cannot reach it. So therefore, it is difficult to achieve a complete resection of the tumor in the suprasedial region in this case, and its treatment is one of the challenges for us. So the simultaneous combined endoscopic and the nasal and the transcranial surgery was employed. But how about this kind of two approach compared with for in comparison? And we enrolled our cases with 31 cases for CECS and 23 for EES. And this is the demographic and clinical data of the patients in these two groups. And we can see there's no significant differences. And this is the tumor imaging data of these two groups. And also there are also no differences between these two groups. And for the purist EES, we can see that there's a tumor in the sedal region, and which invades to the suprasedial area in the right side. And after the tumor was removed, we can see a breakthrough here, but it is not easy for us to see if there's a tumor residue in the suprasedial area. So after the surgery from the MR, we can see a tumor residue here. And this is the layout of for the CECS, and this is for the transcranial surgeon, and here is for a here is the transnasal surgeon. Here is for a transcranial surgeon, and this is our surgical layout here, and two surgeons. This is the holder, and during the surgery, we can find that it is easy for the two surgeons to see the each other's field, surgical field from the screens here for cooperation. Here we can see the first case is a tumor invade and into the paracerial region. We use the micro Doppler to detect the position of the IC and cut open the duro. And first step, we make the tumor debulking in the cellar, and after that, the brain tissue, the pressure of the brain was relieved, and then we trying to use our transcranial approach. And for a transcranial approach surgeon, there are two processes for him to do. His first step is to remove the tumor which penetrates throughout the diaphragma center. And the second process is to draw and pull the tumor towards the intermediate orientation to help the transnasal surgeons to resect the tumor. And during this process, we have to carefully concerned about the protection of the arteries or nerves in this area, because we can see from the two approaches, it may help us to make the judgment about this, which is difficult for the EES approach only. Also here we use the fat and the fascial for the reconstruction work. And from the transcranial view, we can see there's no bleeding here, which cannot be seen from the transnasal view. And this is the CT scan of the, and this is the MR images. And the second case is the tumor invaded in the dirty ventricle and lateral ventricle system. As before, we also do the tumor debugging work. And when we trying the tumor in the superior area of the center, we find that it's not easy for us to reach the tumor at that high. So we employ another approach for the tumor section. And from the transcranial view, we just wait for the delivering of the tumor from the transcranial approach. And we don't need to use an endoscope or use a very difficult resection manipulation. And also we can make a judgment by these two surgeons to make sure that there's no injury to the nerves or arteries or fibers. We can see that for the transnasal surgeons only use the sections to remove the tumor, and after the tumor was mostly removed, we can see that the ventricle system, the brain tissue interface is exposed. And this is the post-operative MR and the CT scan. And for the third one is the a tumor with a lobulate growth and extends to the supracell region. And we resect the tumor in the center and in the cavernous sinus. And when we're trying to reach out reach the tumor in the superior part, we find it is not easy for us to reach it. So we employ another approach to help us to resect the tumor, because we cannot just see the tumors in the superior part of the center. And after that, we make a full tumor reconstructions. This is the post-operative CT scan. And this is a hard texture tumor. Not like the tumor, not like the soft tumor. We found that after we resect the tumor in the center, the tumor in the superior part did not decline. So it is not easy for us to resect this kind of hard texture tumor only by the nasal approach. And combined with the transcranial approach, we push the tumor into our transnasal approach. And after that, we also make a combined reconstruction works. This is the fat. Okay, this is the post-operative images. So, and for the parameters, we can see the extension of fluoration for the CECS is higher than the ES, as well as, but for intra-operative rod loss and the operative time is higher for the CECS than the ES. And for the post-operative reading, the CES is better than the ES. And for the recurrent rate and the operation rate, the CECS is also performed better than the ES. So let's make a conclusion about that. Its first point is the CECS is safe and feasible with better tumor removal and less post-operative bleeding than the pure ES. And for the CECS, the tumor is guided to the endoscopic view by the transcranial surgeon, and clear visibility enables precious tumor removal, enhancing the surgery safety and minimizing recurrence. And the third point is the tumor breaks through the center diaphragma and removed by the transcranial surgeon, and preserving the center diaphragma integrity, which will reduce the CSF leak as well as maximizing tumor removal. And the fourth point is direct visualization protects the arteries and nerves from the supercellular tumors, and minimizing the bleeding after surgery. And we can using the intracranial channels to strengthen the setup for repairments and lower the CSF leak risk after surgery. Thank you for your attention.
Thank you, Professor Jiang. So any question from the audience?
We can, I guess, Liu, would you like to ask something?
Yeah, and no specification. It's very good surgical procedures. Just probably just in case, do you find that with combined approach, the position of a fat pad is better placed rather than just come from transphenoidal approach? And do you put glue also from above? I mean the tissue glue, or just from below? Thank you.
And for most of the case that we use the transcranial approach in the left side of the patient, but if the main body of the tumor is in the right side, maybe it's not easy. It is difficult for us to use the right side incision, but it is. But if we can do the good layout for the corporation, we also use the right side for the transcranial position with the endoscope transnasal approach here, or in the right side of the patient here.
The question was, do you use the fat from above or below?
For a reconstruction?
Yes.
We use the fat below and above.
From both ways. And do you use the glue?
Glue, yes, we use the
Fibrin
glue
glue. From both above and below.
below.
Fine. Thank you very much. Yes, Prakash.
Ian, congratulations, great talk. My question is, what type of craniotomy do you use for these patients? Do you use a full terional craniotomy or a minimally invasive supraorbital craniotomy?
We use the just the small incision here in the right side here.
Is it on the eyebrow?
No,
No, it is on the terion.
yes,
Okay.
here.
Thank you. Thank you very much.
And how do you position the head, especially when you're doing a right-sided case? Do you turn the head towards one side or do you keep it absolutely straight?
It's not straight. It's not straight because we have to keep a good position for the transnasal surgeon. So the straight is not good for the transnasal surgeon. A little bit, right?
Towards the opposite side, is it?
Yes.
Okay.
How do you manage when you're doing a right-sided tumor? Because on the right-sided tumor, you will still have to turn the head towards the left side. And that becomes a little difficult for one of the surgeons.
Yeah, the right side is difficult, but it is also available for us.
Okay, thank you. Prof. Oyama?
Yes, Professor Jaron, thank you very much for your lecture. I completely agree with your opinion. This technique really reduces the risk of the post-operative intratumoral hemorrhage and sink. And can you please tell me your indication for the combined surgery?
Okay.
So you mean you perform the combined surgery for the every giant pituitary tumors, right?
Most of us.
Because you showed the 4 cases, and the last case, I think I can remove the tumor just by endoscopic endonasal surgery because the tumor shape is really smart. I mean, like
we make a judgment before surgery. We can see that from the MR image. We may concern about the texture is not so soft, but we did not just use when we find that the heart is the texture is hard, and then we employ the transcranial approach then.
But for me, I will do perform the drilling of the clivus a little bit and make a corridor bigger for the transnasal surgery. I think it's
yeah, I understand, like the like we do the cranial pharyngioma or that extended approach, right? Yeah, we think it is also a good approach for that.
If I may ask you one question, have you find any difference in the rate of infections when you do pure endoscopic and the combined approach?
And we found that the infection rate is higher for a CECS, but it's no significant differences. And we have some point to control the infection rates, such as we did not use the water when we just have to the breakthrough view of to find that if we doing the corroboration surgery, we do not just use the water in it from the transnasal approach, and because we know that will increase the rate of infection of the surgery, but we didn't find any significant differences, but we have seen the trends.
Okay, thank you. Prof. Mathur is back with us.
Yes. Sorry, I got disconnected. My computer just gave way, so that's the reason. No, it's excellent demonstration of a fantastic technique, and it's. I think it is. It looks like that it should be much more safer doing a combined technique in these sort of giant lesions, as you have told in your classes of 1, 2, 3, 4. That's what should be. I think Professor Kenichi will agree to that.
Yeah, I agree with you.
And do you think that the outcome is better with this combined technique as compared to a solitary technique?
Yeah,
Yes. Okay, fine.
all the reflection rate is better than the ES.
Okay, thank you. Thank you very much. I think with that we can conclude this session. Prof. Oyama, any concluding remarks from you?
No, thank you very much for everybody to join this great webinar. We have a great lecturers, two lecturers, one from India, one from China. So thank you for Raja for giving us this great opportunity, and see you again in this webinar.
I'll wind this up officially on behalf of the Education Committee of the ACNS and the President, Prof. Yuko Kato. I would like to thank both the speakers of today, Prof. Ashish Tandon and Prof. Sian Ziarong, as well as the chairs, Prof. Noriro Sakai and Prof. Kenichi Oyama, for this time and support for the ACNS webinars. A very special thanks to Prof. Shubin for broadcasting this webinar on the WeChat channel. As I mentioned earlier, we have around 512 people who joined us from all over the world. A special thanks also to my co-host Liu Boon Singh for joining me today. So until we all meet online tomorrow, it is bye-bye from all of us. Thank you very much for joining.